We'll cover its course, constrictions, blood supply, nerve control, and clinical importance. Let's begin. The esophagus is the muscular tube that connects your throat to your stomach. Its job is to move swallowed food and liquid downward. A key feature that helps it do this is the secretion of mucus, which provides essential lubrication. Now let's talk about its size. In an adult, the inner diameter of the esophagus is only about 2 centimeters when it's at rest. That's roughly the width of an average person's thumb. The adult esophagus measures roughly 25 centimeters or 10 inches in length. To give you a better idea, that's about the length of a standard pencil or the size of a small ruler. The esophagus originates in the midline at the pharyngoesophageal junction. This is anatomically located at the lower border of the cricoid cartilage, opposite the C6 vertebra. The esophagus completes its journey by piercing through the diaphragm and terminating at the stomach. It ends by opening into the cardiac orifice of the stomach. This endpoint is positioned slightly to the left of the body's midline and lies opposite the 11th thoracic vertebra, or T11. To understand its course, anatomists divide the esophagus into 3 main parts, based on the body regions it travels through. First, the cervical part. This is where it all begins. It extends from the starting point we discussed, the pharyngoesophageal junction at C6, down to the thoracic inlet, the doorway into your chest. Next, the thoracic part. This is the longest segment running down your chest cavity or mediastinum, right behind your heart and windpipe. For more precision, we can even subdivide this thoracic part into 3. The upper thoracic segment, from the chest inlet down to where your windpipe or trachea splits into 2 bronchi. The mid-thoracic segment, which continues from that split about halfway down to the stomach. And finally, the lower thoracic segment, which completes the journey to the diaphragm. Importantly, this last bit includes the very short section that will soon pass into the abdomen. Finally, the abdominal part. After piercing the diaphragm, we have this shortest terminal segment. It's only about 1 inch or 2.5 centimeters long, and it connects directly to the stomach at the cardiac orifice we just talked about. Let's meet the first major valve, the upper esophageal sphincter, or UES. Location-wise, this sphincter is the gatekeeper at the very beginning of our journey. It sits precisely at the pharyngoesophageal junction, right where your throat ends and the esophagus begins. Anatomically, it's not a separate ring of muscle. Instead, it's primarily formed by the cricopharyngeus muscle, which is part of the lower pharyngeal constrictor. Think of it as a specialized, always-on muscle sling at this junction. Its function is brilliantly dual-purpose. At rest, it remains tonically contracted. This sealed state is crucial. It prevents air from being sucked into your esophagus and stomach with every breath. During swallowing, it receives a signal from your brain to completely relax for about 1 second. This brief opening is the critical window that allows the food or liquid bolus to enter the esophagus while preventing it from going back up. And at the other end of the journey, we find the second and crucial gatekeeper, the lower esophageal sphincter, or LES. Its nature is fascinatingly different. Unlike the upper sphincter, the LES is not a distinct anatomical muscle you can see under a microscope. Instead, it is a 3 to 5 centimeter long functional high-pressure zone at the distal esophagus, created by a complex interaction of the surrounding muscles, the diaphragm, and the angle at which the esophagus enters the stomach. Its function is absolutely vital. It acts as the primary physiological barrier against gastroesophageal reflux. It relaxes transiently during swallowing to allow the food bolus into the stomach in response to primary peristalsis. Also relaxes spontaneously in response to gastric distension after meals, known as transient LES relaxations, TLESRS, which is the main physiological cause of simple, normal reflux. Remains tightly closed and contracted at all other times, protecting us from harsh stomach acid. The esophagus has 4 normal constrictions that are crucial for endoscopy and understanding disease. We measure their location by distance from the upper incisor teeth. First, at 15 centimeters, 6 inches, the pharyngo-esophageal junction. This is the upper esophageal sphincter, UES, at vertebral level C6. It's a common site for Zenker's diverticulum and requires careful navigation during endoscopy. Second, at 23 centimeters, 9 inches, the aortic arch constriction. The esophagus is crossed by the aortic arch at level T4. Its pulsation may be visible during endoscopy. Aortic aneurysms here can cause dysphagia. Third, at 28 to 30 centimeters, 11 to 12 inches, the left main bronchus constriction, crossed by the left bronchus at level T5 to T6. This is a potential site for a bronchoesophageal fistula, especially with malignancy. Finally, at 40 centimeters, 15 inches, the diaphragmatic hiatus. This is where the esophagus passes through the diaphragm at T10. It corresponds to the lower esophageal sphincter, LES, and is the primary site for hiatal hernias and GERD. The esophagus receives blood from different arteries along its course, segmented by its anatomical divisions. For the cervical part, it is supplied by branches from the inferior thyroid arteries, which arise from the thyrocervical trunk. For the thoracic part, the main supply comes from small, direct aorto-esophageal branches off the thoracic aorta. It also receives additional branches from the bronchial arteries, superior phrenic arteries, and the right third to seventh intercostal arteries. For the abdominal part, the primary supply is from branches of the left gastric artery, a major branch of the celiac trunk. Additional supply comes from the splenic artery and the left inferior phrenic artery. The drainage starts in a rich submucosal venous plexus within the esophageal wall. From there, blood follows 3 main routes. From the cervical part, veins drain into the inferior thyroid veins, then to the brachiocephalic vein, and finally into the superior vena cava, SVC. From the thoracic part, blood drains posteriorly into the azygos and hemiazygos venous system, which also empties into the SVC. From the lower thoracic and abdominal parts, this is the critical pathway. Veins drain into the left gastric vein, which feeds directly into the hepatic portal system. The flow starts in a network of vessels within the esophageal wall. Lymph then drains to specific lymph node groups based on location. From the cervical and upper thoracic esophagus, lymph drains upward to the deep cervical lymph nodes in the neck. From the mid-thoracic segment, it drains to the periesophageal lymph nodes located within the superior and posterior mediastinum of the chest. From the lower thoracic and abdominal esophagus, lymph drains downward to the celiac lymph nodes around the aorta and the perigastric lymph nodes near the stomach. The esophagus has a sophisticated two-tiered nervous control, an intrinsic gut-brain and extrinsic autonomic nerves. 1. The intrinsic system, enteric nervous system. This is a self-contained network within the esophageal wall. The myenteric, Auerbach's plexus, located between muscle layers, coordinates peristalsis. The submucosal, Meissner's plexus, regulates glandular secretions and blood flow. Together, they provide autonomous local control. 2. The extrinsic innervation. This provides central nervous system input. A. Parasympathetic. Vagus nerves, CNX, the primary motor driver. For the upper one-third, striated muscle, it provides voluntary, direct control to initiate swallowing. For the lower two-thirds, smooth muscle and LES, it is involuntary, synapsing with the myenteric plexus to coordinate peristalsis and trigger LES relaxation. Key detail: after the hiatus, vagi form the anterior and posterior vagal trunks for abdominal innervation. B. Sympathetic, T2 to T8 segments, acts as a modulator. It generally inhibits peristalsis and secretions, contracts sphincters, UES and LES, and causes vasoconstriction.